again, this is Dr. Castanet. I'm going to review some cervical and lumbar imaging with you today. This patient is very interesting. He brought this imaging to me. He's had 2 surgical opinions. He was told he has stenosis of both the neck and the low back, and that they want to do surgery for his cervical stenosis and then do surgery for his low back stenosis. His clinical picture is as follows. The neck complaint doesn't bother him in the way of pain. He doesn't have any symptoms related to that. That, by the way, is not uncommon in cervical stenosis. It's quite common to not be symptomatic and yet have this asymptomatic stenosis or narrowing of the canal in the cervical region that can give rise to the typical findings of somebody with cervical stenosis. Usually starts with a loss of finger dexterity. There can be gait disturbance, not in the way of a typical antalgic gait that you might find in somebody with low back pain, but rather in somebody with a spastic, uncoordinated, ataxic gait. So, for example, I had a patient years ago come to me. He'd been treated elsewhere and was being treated concurrently at 2 other places. And I think he was just kind of neglected by the physicians. He was seeing the physician assistants, and I'm inferring that they hadn't seen the clinical picture of cervical stenosis before. So anyway, this gentleman was seated in my waiting room. I came out and saw him. I asked him to come back to the room. He stood up, and right away I could tell he had a spastic gait. So I said he could sit back down. I told him he probably had cervical stenosis. He needed a stat MRI scan. In fact, he did have cervical stenosis severe. The following week, he wouldn't return my calls. He called me 8 days later in the morning and tells me he can't get out of bed, he can't move his legs, can't get up, all that. So I called the neurosurgeon. The neurosurgeon had him in 4 hours later into his office, and the following 2 days, he had a reconstruction of his neck with a corpectomy where they removed some of the vertebrae, the vertebral bodies, and put in replacement there and decompress his cord. By then, his cord had been compromised for too long, and his outcome was not as good as it otherwise would have been, but it certainly stopped the progression of what would have been worse, loss of function. Anyway, as for this patient, you can see, and I'm sorry, the quality is not great, but you can see the vertebrae have collapsed upon each other. He has long-standing disc degeneration, very minimal disc space left there and there and there. You'll be able to see this on his cervical MRI scans, which I'll show you in just a second. Let's go to the next image. We're going to go to the cervical MRI. This is interesting because he's got a pretty wide canal here. I don't see any significant cervical stenosis. Yes, he's lost his cervical curve. He's a little kyphotic in this area here. There's disc herniation there, small and modest. Some disc ossified complexes and herniations anteriorly that sometimes cause problems with swallowing, but he's not complaining of that. This stripe right there is the spinal cord. I don't see, and this is not great contrast here, so it's hard for me to evaluate this reliably, but I don't think there would be any cord damage here based on this. I don't have the records as yet, but it's not so narrow or so threatening at any of these levels that it's likely to have injured the cord on extension or something like that. Let's go to the next image. Here's a cervical cord, T2 image. You see it's a little narrow at that point, but the cord looks good through there. There could be some cord signal change here. I'd be curious what the radiologist said about this, but he's not that stenotic. On the other hand, if there's a cord signal change here, maybe there or there, then as a preventive measure, he may be recommended to have cervical decompression surgically at this level to protect his cord. So that would be a very reasonable recommendation to make by a surgeon. Let's go to the next image. This is his low back. Now this is interesting because at this level, it looks very narrow to me, very stenotic at multiple levels. So this looks to me that he has possibly congenital stenosis. That's where the pedicles are short, so the canal is smaller than usual. And then as the person gets older and they acquire superimposed degenerative changes, then it becomes very stenotic and problematic. At this level, you see there's a retrolisthesis of L3 as it collapsed on L4. The discs look reasonably good here, but between the disc herniation here and the ligamentum flavum hypertrophy here, it's very narrow in this sagittal slice. At this level, at 2, 3, 4, again, you have a disc herniation there, some ligamentous hypertrophy there. At this level, you have intravertebral herniation, superior end plate degeneration and deformity. Same thing at that level. So this looks like it's very likely a problem. And I think that he does describe, to some extent, not as much as I would expect perhaps, the clinical picture of stenosis. And I should make the point here now that stenosis, that word can be used in two different ways. One, to describe just any narrowing anywhere in the canal, doesn't necessarily have any clinical significance at the time, but the other way in which we use stenosis is a clinical picture either in the neck or the back where it's potentially surgical. In the neck, if we talk about surgically significant stenosis, it means there's perhaps there may be a threat to the spinal cord, impingement on the cord. There may already be some damage to the spinal cord, with or without appreciable signs or symptoms, but usually there are appreciable signs and symptoms when there's cord signal change. In the low back, it describes the picture you often see of people in public. They're bent over, they can't stand up straight, they push a cart and rest on the cart as they move about. They can do that for 5 or 10 minutes perhaps, and they have to sit down and take a rest. That opens up the canal when they're seated, then they stand up, closes the canal again, but they're able to walk for another 5 or 10 minutes before they have to sit down again. And that requires decompression surgically in the low back to open up the space with usually laminectomy at 1 or more levels. There's always the threat after laminectomy of a slip or spondylolisthesis at that level, because when you remove the lamina, you're also removing part of the joints typically, which are enlarged and also contributing to the narrowing and compression of the nerve roots in the low back. Let me go to the next slice. This is his low back, again, x-ray. So you see multi-level disc collapse, very little disc space height left. I'll go to one last image. This happened to be, this is the image from the front. When I looked at his low back MRI scan, the sagittal images, you could tell they looked dissimilar at different levels, indicating that he had some scoliosis or list. So he has some mild degenerative scoliosis. The curvature amount is not significant really, but that's what we see here on the A to P lumbar x-ray. The last film was flexion film. This was taken because the physician wanted to know if there's any spondylolisthesis or slip at any of the levels. That's not the case. He's stable, but very stenotic, and I think he's going to require lumbar laminectomies to decompress his lumbar or low back spine surgically. If I can help you with your neck or back problem, I'm Dr. Craig Castanet in Decatur, Georgia. The phone number is 404-558-4015. The website is backstrong.net, and from there you can go to my YouTube channel to look at a variety of other videos related to neck and back pathology. Thanks very much. Bye-bye.